This video is about clinical ethical reasoning. Clinical ethical reasoning is an approach to add an ethical aspect of thinking to any clinical reasoning scenario. Ethical problems in a clinical scenario often emerge through the dynamic process of the assessment and communication with the person, so this approach also keeps in mind insufficient communication, interpersonal conflict, or incomplete awareness of existing medical information and options. Here you can see the difference between classical clinical reasoning and clinical ethical reasoning. They both start with a problem. To solve the problem, clinical reasoning uses history, exams, or data, whereas clinical ethical reasoning uses medical facts, medical goals, the patient goals, and the context. This leads for both to a differential diagnosis and clinical or respectively ethical assessment. Through further diagnostic evaluation or further information and dialogue, the clinical reasoning process ends with a treatment plan and the clinical ethical reasoning process with the best course of action. The clinical ethical reasoning can be implemented practically with the 6-step approach. The first step is to state the problem plainly. Afterwards, you gather and organize the data, which consists of the medical facts, the medical goals, the patient's goals and preferences, and the context. Thirdly, you ask, is the problem ethical? Step 4 is to ask if more information or dialogue is needed. The 5th step is to determine the best course of action and support it with reference to one or more sources of ethical value, which are ethical principles like beneficence, non-maleficence, respect for autonomy, and justice. Rights, which are protections that are independent of professional obligations, consequences that are estimation of the goodness and desirability of likely outcomes, comparable cases that are used for reasoning by analogy from prior cases, professional guidelines like AMA Code of Ethics, ACP Ethics Manual, or BMA Handbook, and conscientious practice, which means preserving the personal and professional integrity of clinicians. The last step is to confirm the adequacy and coherence of the conclusion. Let's demonstrate it on an example. A 68-year-old woman is admitted to the hospital with right-sided weakness and confusion. Her examination reveals unintelligible vocalizations, intact papillary reflexes, absent gag reflex, impaired swallowing, and right hemiparalysis. Magnetic resonance imaging of the brain shows acute infarction, a stroke, involving the left frontal, parietal, and temporal lobes. Supportive care is instituted, including intravenous hydration and a nasogastric feeding tube. The patient does not have an advance directive or medical power of attorney. Her family decides that she should not be resuscitated in the event of cardiac arrest. Her mental status fluctuates. At times she is able to recognize her family. On hospital day 4, she pulls out her nasogastric tube and it is reinserted. On hospital day 6, the attending physician recommends the insertion of a percutaneous endoscopic gastrostomy, short PEG, tube for longer-term enteral feeding. The physician explains that the prognosis is too uncertain to justify a shift to palliative care and emphasizes the need for nutritional support while neurological rehabilitation is attempted and the prognosis clarified. The family disagrees and requests that the patient be discharged home where they are willing to let her go. The first step identifies what has triggered the perception that an ethical problem exists. Like the chief complaint that begins an evaluation in clinical medicine, the problem stated in straightforward terms helps focus attention on the problem with as little prejudgment as possible. The problem in our example is that the physician believes the PEG tube should be inserted, but the family disagrees. The second step is to gather and organize the data. First, the medical facts. They include the patient's condition, diagnosis, prognosis, mental and emotional status, decision-making capacity, as well as the benefits and burdens of treatment options and their probabilities of success. In our case, the patient has had an acute stroke resulting in aphasia, impaired swallowing, hemiparalysis, and fluctuating mentation. Her prognosis is unclear. She doesn't have decision-making capacity. PEG tubes have known risks, but they avoid the discomfort and limitation of nasogastric tubes. Afterwards, the medical goals. Articulating the goals of care facilitates discussion that is oriented by concrete and feasible objectives. Common goals include preventing disease, curing disease, restoring function, relieving pain, prolonging life, and comforting suffering. It is important to distinguish between disagreements about goals versus disagreements about different ways to accomplish the same goal. Medical goals have received considerable attention in end-of-life care discussions, but should not be limited to this setting. In our case, the medical goals include relieving discomfort, maximizing neurological recovery, and prolonging life in order to clarify the prognosis. C. The patient's goals and preferences. The medical goals of care need to be placed in the context of the patient's assessment of the benefits and harms posed by treatment options. A patient's values and beliefs will define his or her personal goals and determine how best to achieve them. Discussion of goals may prevent misunderstandings that arise when individual diagnostic or therapeutic decisions are isolated from the overall clinical situation, the big picture. Refusal of medical advice should be a red flag, inviting deeper exploration of the patient's goals and preferences, and should not automatically be interpreted as a lack of decision-making capacity. When a patient lacks decision-making capacity, advance directives and valid surrogate decision-makers should guide the determination of the patient's wishes and best interests according to the local legislation. In our case, the patient lacks decision-making capacity and has no advance directives. Her husband with the family is her surrogate decision-maker. He believes that she would prefer to die comfortably at home rather than have a PEG tube inserted and struggle through the uncertain outcome of her stroke. D. The context. Patients bring to the medical encounter a personal context that may bear heavily on their perceptions, preferences, and understanding of options. They may be influenced by family bonds, social or economic circumstances, prior healthcare experiences, a history of racial discrimination, or religious traditions. Physicians have contexts that are shaped by professional culture, economic conditions, legal obligations, and healthcare systems, and they work alongside clinicians in other health disciplines who have their own moral standing. In our case, the family appears to have the patient's best interests in mind. No institutional or economic constraints on the decision-making process are evident. In the state where the patient resides, statutory law leaves open the possibility of legal liability for withholding life-supporting therapy because the patient does not have an advance directive or is not deemed terminally ill or permanently unconscious. The third task is to determine whether the problem is primarily ethical, that is, whether it involves moral questions related to values, principles, commitments, obligations, rights, and so on. A differential diagnostic evaluation includes the possibilities of poor communication, strained interpersonal relationships, or incomplete exploration of medical alternatives. If the problem is ethical, it should be defined in order to confirm or question a shared understanding of the problem. Possible conflicts between competing values should also be identified. In our case, the disagreement between the physician and the family regarding the insertion of a PEG tube is an ethical problem, involving competing assessments of what is in the patient's best interest. The physician may need to collect more information about the patient's goals, search the medical literature to explore medical alternatives, engage administrators and insurers, or take steps to repair misunderstandings or restore trust. Some ethical and non-ethical problems will resolve solely with the addition of more information or dialogue. In our case, the physician should consult experts and literature regarding prognosis in patients with middle cerebral artery infarcts and the effectiveness of PEG tubes in stroke rehabilitation. The necessity of a PEG tube at this exact juncture should be probed. dialogue with the family should explore the grounds of their belief that the patient would not want a PET tube. The fifth step is to determine the best course of action and support your position with reference to one or more sources of ethical value. The bioethical principles are respect for autonomy, beneficence, non-maleficence, and justice. In our case, both the physician and the family are trying to maximize the patient's good and avoid harm, but their contrasting definitions of benefit and harm lead to competing conclusions. The physician views the possibility of neurological improvement as a benefit and premature death as a harm. The family views comfort care as a benefit and the prolongation of suffering as a harm. The family shows respect for the patient autonomy through their substituted judgment based on prior knowledge of the patient's values. The physician relies on a best interest standard that carries a presumption of treatment in the absence of a clear expression by the patient to the contrary. Questions of justice might arise if treatment decisions discriminated against the patients on the basis of financial status, cognitive capacity, and so forth. In ethics, we may be aware of paradigmatic cases from our own clinical experience, professional literature, or important court cases, for example Quinlan, Conroy, or Cruzen, against which we compare a present case. Reasoning proceeds from the circumstances and conclusions of an unclear case to the circumstances of a less certain one. If the two cases are sufficiently alike to justify comparison, their similar circumstances may justify similar conclusions. This might differ in different countries legally. For our case example, the case of Claire Conroy is analogous, involving an 84-year-old woman with severe impairments whose nephew sought to have her nasogastric feeding tube removed. The court emphasized that patients retain the right to decline any medical treatment, including technological feeding, when they lose decision-making capacity. Although consensus is lacking on some issues, professional ethical guidelines serve as important references. Examples include the American Medical Association's Code of Ethics, the American College of Physicians' Ethics Manual, and the British Medical Association's Handbook of Ethics and Law. For our case, the general guidelines about withholding life-sustaining treatments from incapacitated patients are available. Conscientious practice reminds us that the physicians have their own ethical integrity that warrants respect. Patients, colleagues, or administrators should not be allowed to compromise a physician's integrity, which is both personal, the beliefs and values we bring to the practice of medicine, and professional, the beliefs and values the practice of medicine requires of us. Physicians may act according to conscience and decline participation in decisions that are considered unacceptable. Physicians who disengage from a patient's care should arrange a transfer of care in order to avoid the ethical and legal violation of patient abandonment. For our case, it means if the physician's recommendation to support the patient with PET tube feeding presents a fundamental commitment to the patient's best interests, complying with the family's request to forego life-supporting treatment may compromise the physician's integrity. Intractable disagreement between the physician and family might warrant transferring the patient's care to another physician or the consideration of judicial review. The last step is to confirm the adequacy and coherence of the conclusion. In clinical medicine, the correctness of a diagnostic conclusion is tested by using the criteria of adequacy, so the diagnosis accounts for all the patient's findings, and coherence, which means the patient's findings are consistent with the described pathophysiology of the hypothesized disease state. Clinical ethical reasoning may not be able to achieve this degree of confirmation, but a conclusion should be as adequate and coherent as possible. Failure to fulfill these criteria in clinical medicine forces the physician to question the diagnosis being entertained and consider a shift in clinical reasoning. Similarly, when clinical ethical reasoning produces conclusions that do not fit the known factors of a patient's case or are incoherent, additional ethical analysis or consultation is needed. For our case, that means that the physician's insistence on nutritional support during a period of rehabilitation is ethically justified on the basis of the physician's assessment of benefits, harms, rights, possible outcomes, and conscientious practice. Even so, each of these sources of ethical value is open to more than one interpretation, as evidenced by the contrasting position of the family. The physician's assessment adequately engages the ethical issues at stake using values that form a coherent ethical picture. The physician's assessment does not prove that a position is right or solve a problem. Rather, it justifies a course of action by articulating an adequate and coherent ethical explanation. We hope that you enjoyed